Hello, I'm Dr. Russell Libby, and I welcome you to the world of medicine. Today's show is about heart disease. Now, although we have other things going on in healthcare reform, swine flu, all kinds of things related to bioterrorism, heart disease, cardiovascular disease, which really means stroke, hypertension, and defects of the heart attacks, things of that nature, is by far the leading cause of sickness and death in our country. Somewhere close to 37% of our population has some form of cardiovascular disease. Close to 900,000 people die from some cardiac-related problem on an annual basis. And by far, it is the most expensive condition that we deal with in our country. In fact, the direct medical and the indirect, just lifespan costs of heart disease is somewhere in the $500 billion per year range. So when we talk about significant diseases, we live with it every day. Now, we also live in a society that seems to really provocate, to create a backdrop for people to have heart disease. Obesity is a huge problem in our country. Inactivity. Well, we're going to learn about risk factors with heart disease. We're going to learn about how we evaluate, how we treat, and we're going to learn a little bit about some of the more incredible interventions that are available now. Ways to treat heart disease and heart problems that no one could ever have imagined 10, 15, 20 years ago. We've got a great audience, people willing to share their stories with you. They're going to help you understand what they've experienced so that you might better understand what you can expect if you have some kind of heart problems. We have also some experts who help take care of these patients in the outpatient arena. Cardiac rehab's a big part of it. And we have a regional expert, Dr. Paul DiLorenzo. He's a cardiologist with Fairfax Heart Associates. He works out of Inova Fairfax Hospital in Inova Alexandria. So as we usually do, we start the show coming out and talking to our audience and asking heart problems. Have you had a heart problem?
I didn't know I had a heart problem until about a year ago. Then I had a heart attack.
So you've got a real issue.
Yeah, sure do.
You had no idea coming into it that that was an issue for you. So
No idea. I have like zero risk factors at all. I'd be like the last person to think of someone having a heart attack.
right. Well, you have to take care of him. Was he the type of person you might suspect?
No, not at all. It was a complete surprise for both of us.
Complete surprise.
Yes.
Fantastic. And have you had a problem with your heart?
I have indeed. I had a heart attack when I was 51 years old in 2001.
51. Wow. Okay, that's a young age for
It
a heart
is,
attack.
it is.
For anyone, but especially a lady.
Mm-hmm.
We're going to hear more about what happens and what's special about women and their heart. How about yourself?
Yes, I had a little problem, but it was not a heart attack, fortunately. I was one of the fortunate ones. I came within a fraction of an inch, probably, if you can measure it that way, of having a heart attack, but just missed it thanks to a good friend who took me through red lights and evening rush hour to get me to the emergency ward.
We're going to hear about what that means and how that happened to you. Have you had a heart problem?
Yes, I have. I was resting one day and got this tightness in my chest. What's going on here? And I said, I don't feel right. Something's wrong. I never felt this way before. So I called the doctor. He's come in. He examined me, says, I'll be right back. So he goes out of the room and comes back and he says, I want you to go see Dr. Schwartz. I said, who is Dr. Schwartz? He said, he's a cardiologist. I said, what? And he said, yes. He said, I hear something that I don't like. So I went to see Dr. Schwartz and he put me into the hospital immediately. And the next day we did angioplasty. He put a stent in that did not work and did something else. I don't recall exactly what it was. But they went in twice through the groin, and then I went upstairs, and the rest is history.
Well, fortunately, upstairs wasn't too far upstairs.
No, not that
We're talking about
upstairs.
upstairs in the hospital.
No, not that
Right.
upstairs.
Okay, well, that's great. Well, we're going going to hear more about what that's all about. And you've had some heart issues. You look like a pretty burly guy. I can't imagine.
Well, 17 years ago, during a routine physical, I was diagnosed with a bicuspid aortic valve, which is a congenital defect. And I really wasn't aware of any symptoms I was having. But 6 years later, I had to have it surgically corrected, open heart surgery.
Wow. So we're going to hear about those kinds of things, congenital heart defects. And we're going to find out from you, I guess, something else. I know you very well just because you're here to talk about
My son Andrew.
your son, Andrew.
My
yes.
son Andrew, as it happens, was seen in Dr. Libby's practice for 22 years, and Dr. Libby saw him on occasion, and also Dr. Weinstein took excellent care of him. But he was born with congenital heart defect, missing a chamber of his heart and a valve in his heart, and has had 27 open heart surgeries, which we've traveled up and down the coast to get. And he's doing very well right now. He's 24, his health is stable at the moment, and everything seems to be clicking along thanks to good medical care and being vigilant. So,
Well, that's great.
it's been
And
an
we're going to hear
experience.
a little bit about his story. Do you know Andrew? Dr. DiLorenzo? Well, he's
Not
a
at all.
remarkable story, of course. And yourself.
Well, I have a pacemaker.
You have a pacemaker.
Yes,
Perfect.
and I was having some pretty severe symptoms, mainly my heart pounding for a couple of months, shortness of breath, weakness in my limbs. I wasn't able to take my walk that I had taken every day. I just couldn't do it. And when my pounding heart started waking me up in the middle of the night, I knew I needed help. And that it all happened in the course of a day. It was very, very exciting. I was able to get in to see Dr. DiLorenzo and in the morning, and by that afternoon, I had a pacemaker.
Well, we're going to hear about that kind of process and what happens to you. Have you had heart issues?
Not directly, but I had high blood pressure, high cholesterol, diabetes. I weighed 340 pounds. And so, no doubt in my mind, I was headed that way. So I was digging my grave with a knife and a fork and a ice cream. No doubt in my mind, I was headed that way. So I was digging my grave with a knife and a fork and a ice cream spoon. And just seeing those health issues in my life, and then also my wife's mother had a heart attack very early in her life, and then my father-in-law, who actually lived with us for 17 years, he just died of heart disease last year. And so I saw him go through open heart surgery and things like that. And I'm also a pastor, so I was at the
You have
hospital.
people depending on
Yeah, I
you.
was at the hospital today. Somebody got a pacemaker, and so I'm around this stuff a lot.
All right. Well, we're going to hear more about what you do with your weight, because if you can lose weight like that, I hope anybody really can, right? Sure. And yourself?
Never actually had a heart problem, but I had gained 60 pounds. I had alarmingly high cholesterol, triglycerides. I had diabetes. I had high blood pressure, a sedentary lifestyle, and a waist circumference of over 35, which gave me metabolic syndrome. I also have a high risk because everyone in my family has died of a heart attack. And because of the metabolic syndrome in my family history, it put me at the highest risk for having a heart attack.
We're going to talk about metabolic syndrome a little bit later. But in talking about your family, I mean, that's something you're telling us, that you were huge. You didn't really pay much attention to your lifestyle, yet everybody around you had heart disease.
I had a cardiac thoracic surgeon actually say to me that this was what my future was going to be. But when both my parents died, I became very depressed. And my daughter pleaded with me to make a change because I wasn't going to be around for her children. It was at that moment I knew that I had to do something. But I had such a sedentary lifestyle that the only exercise I was getting was going from the dining room to the kitchen to get my breakfast, which was cookies, chips, and cherry Coke.
And you're the one who got her to stop eating that way?
Yeah.
Were you eating that way?
No, I was not.
Thank God. Because usually those apples don't fall far from the tree.
No.
So you were a little bit more wise, I guess.
After watching it, you don't want to participate in it.
Yeah. Well, that's a good idea. That's a good thing. And of course, you had to enable.
Yes.
Yeah, of course.
I mean, I also want to say that I had sleep apnea, and she would come in my room in the middle of the night to make sure that I was still breathing. But I think the esophagus surgery was the last straw because I would eat and then lay down, and they had to scrape my esophagus. And I think it was at that moment knowing that my child was going to go off to college the next year, that I didn't want her to have to worry. So it was at that time I went and I knew I had to do something, and I said, you know what, this is my last ditch effort. If this program that I had seen traveling on the road called the Losing to Live program didn't work, being a success-oriented person that I am, I was going to get a lap band surgery. And then one day I went into the Losing to Live program, and it's a faith-based program that deals with small, simple changes. I started with 5 minutes of exercise a week. That's it. And I kept feeling more and more empowered as I was able to do it. These small changes until last June I did my first 5K. I'm now training for a 10K. And I also started shopping at the perimeter of the grocery store, eating the live foods that were fresh and good for me. And my whole life has changed.
Well, we're going to hear some more about that. We need to understand really where people have to go with prevention. But I want to start with, I guess, really some of the issues pertaining to the symptoms you had when you had a heart attack. What was going on?
Well, I was out for my morning walk, and I just walked down the sidewalk in my neighborhood, and it felt like somebody hit me in the chest with a baseball bat. There's no symptoms, no other symptoms than that. There's no, small chest pains, nothing before that. It just all of a sudden.
So you just had chest pain and you were short of breath?
Well, you really couldn't even talk, and it was hard for me to breathe because it was like somebody hit me in the chest with a baseball bat, and
It was intense.
I just practically collapsed right there on the sidewalk.
And as I understand, you tried to call for help.
Yeah, I did have my cell phone with me, and so I called home, but I couldn't say anything. I was just in so much pain that I just couldn't say anything. But my wife knew that it was me, I guess because of the caller ID, and she knew that I was on my morning walk, and she knew the route that I would take. So she just got in the car and started driving until she found me.
Wow. So Dr. DiLorenzo, here we go.
Yes.
We've heard a lot of interesting stories. First of all, in talking about a heart attack, we've heard someone who had just unbearable pain. And then we've heard from someone who really couldn't believe that there was something like that going on. When people have a heart attack, just to start to break the ground, tell us what are the common kinds of symptoms that they might experience?
Well, first, heart attack is due to a blockage in an artery that feeds the heart with blood. So if you think of what happens is that people will end up occluding the artery potentially, and then that part of their heart dies. Just like if you occlude an artery to your finger would eventually die. So because it's internal, you don't see it, but we see it and it causes consequence. So heart attack is a major cause of death in America. And the arteries develop some cholesterol blockage in them. That blockage I always liken to a pimple. And one day that pimple pops. And when that happens, the coagulation system basically starts to put clot in the artery. And depending upon how fast it works and how much it blocks the artery depends on what happens with the heart attack, how severe it is. So most people with heart attacks conventionally are thought of having chest pain or typical pain. It's located in the chest. It's usually a substernal or beneath the breastbone pain. It typically can radiate or move either into the left shoulder or right shoulder or classically down the left arm. People break out in a sweat. They look ashen. They complain that they can't get their breath. Rarely people say they can't breathe, can't speak because they can't get their breath enough to actually make words. So that's a typical heart attack, and that's what Bob had.
And from what I understand, your heart attack even was more remarkable. Now, you ended up in the emergency room.
Mm-hmm.
What happened there?
I actually went into cardiac arrest while I was there, and then I guess they had revived me, obviously, and then Dr. DiLorenzo put a couple of stents in my heart.
So he really went upstairs.
He did. And back, by the way.
Yeah. Fortunately,
Not the
we were
whole
able to
way up.
grab you by the foot and bring you back down.
You're right. Yeah.
So that's a pretty remarkable. So we have a very symptomatic heart attack. We've got a very fortunate sequence of events that when ultimately that blockage. So you're saying then that the cholesterol accumulates, and that's the most common
Well,
cause
then
for
the
that
cl- and then
subsequent.
clot, once
and
the
that
plaque
clot
ruptures,
gets there.
once the pimple ruptures, so to speak, then the clot forms. That blocks the artery, and in some patients, you will create electrical instability in the heart.
Right.
So then their heart stops, and that's a rhythm called ventricular fibrillation, which Bob had. And that's a good time to find yourself in the emergency room. It's a good time to find yourself in the cath lab. It's a very, very bad time to be out on the street.
Right.
Because if you're out on the street, nobody's there, you don't get grabbed by the leg and come back down, at least as often. So Bob, fortunately, had his event, and his heart stopped in the emergency room. He was quickly shocked back into rhythm. At that time, I had been called. I was actually on the road from Alexandria Hospital, Inova Alexandria Hospital, to Inova Fairfax Hospital, where he was in the emergency room. And I had heard there was an ST elevation heart attack, or a major heart attack, waiting for me, and I activated the heart catheterization laboratory. So we told all the troops to get him to the lab. And then I called back, and I asked what the patient's name was. And they told me his name, and I know him from where we've been friendly. And so I immediately pulled over on the pullover lanes and drove like a maniac to get there. And I was very afraid I was going to be stopped by the police, actually, although I thought they would accept that excuse. I have been stopped once and
Everybody
got away
says
with
that.
it one time. In any case, we went, heart attacks, sudden heart attacks like this in modern times are a true fire drill. We need to get the artery open within at least 90 minutes of the time somebody gets to the emergency room. So we got to the cath lab, and we found a completely occluded artery. There wasn't even a smidge of blood flow through the artery. It was completely blocked with a big blood clot in it. And from the time he hit the door to about, I think it was a little over 60 minutes, is what I saw in my notes. So he was almost 30 minutes below what we needed. We got his artery open, and I didn't get a speeding ticket. And so after his artery is opened, the pain resolves, and what that does is it limits the amount of heart damage. So the smaller heart attack, the less damage to your heart, the less likely you'll die, the less likely you'll have heart failure, the less likely you'll have complications. So that's the advantage of getting that artery open. Then we start medical therapy.
Right. So the heart attack, as we understand it, is basically the loss of the muscle, and what ultimately results in some disorder in the rhythm or the pumping function of the heart.
Correct.
And the complications that occur after that may be related to those kinds of experiences. Now, we'll get more into that if we can, but I want to know about your symptoms. You had a heart attack.
I did. I had a heart attack. For several weeks leading up to the heart attack, I had been having some very strong pains in my upper back, actually in the scapula area. And I thought I just needed a good massage,
Right.
you know. I then had several instances of some tightness in my chest. And the morning of the actual heart attack, I remember I was in the kitchen talking with my sister Tracy on the phone, and the heart attack hit, and like Bob, I had incredible pain in my chest, and I was doubled over on the kitchen table, and I remember my sister saying into the phone, "Take some aspirin, take some aspirin, take some aspirin." And I happened to have a bottle of aspirin in a cabinet nearby, and I grabbed a handful of it, chewed it up and swallowed it. And I think later Dr. DiLorenzo told me that might have saved my life. So
Interesting that good old remedy, we keep that around, even though most people don't take it very often, but it has certainly had a resurgence for this very reason. So you had much more of the characteristic symptoms of a heart attack,
Yes.
but she was leading up to it. So was that, we talk about angina, symptoms of chest pain that people don't quite know what to associate with. Do you think that's what was going on with her back?
Yes, absolutely, because it's easy post facto, because when we took care of the problem, the symptoms went away.
Right.
So it's, again, retrospectively, or looking backward, it's simple. But looking forward, it was very challenging, actually. And she had a stress test, and the stress test was quite equivocal. And her symptoms, typical angina pectoris has the quality of being in the chest, occurring with exertion or mental stress, and being relieved by nitroglycerin or by relaxation, by getting rid of the physical exertion. So her pain, I think, in some ways was somewhat more atypical than it was just described. And we had this equivocal stress test. You would have thought it would have been pretty bad, but it wasn't. And I was beside myself on what to do with her, actually. I was in tremendous clinical indecision at the time. And she and I talked, and I finally said, we just need to get you to the emergency room. So we got her over to the emergency room, and her blood test showed the heart damage. And at that point, once again, it was obvious. She had a very small leak of a blood test called troponin. Hers was an incredibly minor leak, and if I recall, she went to the heart lab that afternoon and really had almost the same blockage as Bob, same place. It's just that hers, there was a tiny little trickle of blood flow that was keeping her heart going, and her pain was coming and going a bit as well, if I recall. So we put a stent in, and that reopened it, and as I recall, at least, her symptoms subsided after that.
So when they went through that procedure, how long did you stay in the hospital?
Oh, golly, overnight? I think I was there overnight.
So it took a lifetime to develop that heart problem, and it was fixed overnight.
Yes,
That's pretty
wonderfully
amazing.
so, and it was my birthday on top of
Oh,
it.
wow.
So that was very nice.
That's great.
But it was interesting because we do have a history of heart disease in my family. My father died of a heart attack at age 58. My father's father died of a heart attack also at age 58. But I never had worried about it because it was always the men.
Right.
I thought that was something that maybe ran in the man's side of the family and not the female's. So.
Well, you sure always think about that, don't you? Think of it that way. But I want to hear a little. Now, you had told us that you were pretty mild in your symptoms. You were.
I mean, excuse me, before that incident,
Right.
nothing. I went to work, I came home, I had 6 kids, I'm working like a fool,
I wonder she had
and nothing. And then I had a day off and I said, I'm going to sleep in today.
So that wasn't stressful, 6 kids and working?
Are you kidding? I had to do it.
All right, okay.
So, I mean, I didn't think it was stress. It was my job, and I did it, and that was it. But
Was there much of a family history for you?
yeah, after I investigated, my mother died from a heart attack. My father, I don't know about their parents. My sister and my brother.
And had that already happened?
No,
How old was your mom when she died?
she was 68,
And your dad?
73.
Okay. So outside of the atypical range, maybe. So 2 things. One, we're talking about women and heart attacks. And we know that statistically, it's about equal between men and women in terms of cardiovascular disease.
But women get heart disease older than men. So men will tend to get their problems in their 50s and women more in their 60s, but there are exceptions as we see today. And the problem with women in heart disease actually is making the diagnosis. So if you look, doctors, once a woman has been found to have heart disease, in spite of every other aspect of our society, they're treated completely fairly. If you look at the statistics, they get the same treatment a man would get with the same heart disease. But the problem is that we have such difficulty in finding heart disease in women and separating out the women that have atypical chest pain and other issues versus the patients that have blocked arteries and are complaining of chest pain. So that diagnostic difference is what accounts for the ultimate treatment differences between men and women. But people should be aware that current data shows once we find heart disease in women, they get the same treatment as men. There's really no difference. And what can you do about making the diagnosis? And that's not easy. You know, again, in some patients, you just need to have a good sense of suspicion. You need to say to yourself, gee, I'm not sure what's going on. These are atypical symptoms, but. So what groups most likely have atypical symptoms? It's usually diabetic patients will most often not have chest pain. It's people who have bypass surgery. That probably interferes with their nerves. And it's very old people. So the older a person is in their 80s or something like that. And to some extent, it's women as well, although the first three are the most pronounced. So in those patients, in those different groups, people can prevent with fainting. I've seen a lot of people who faint and it's a heart attack. They can present with fatigue. Most commonly, they'll present with shortness of breath. They just can't get their breath, but there's no chest pain at all. So again, what doctors need to do and what patients need to do, what you all out there need to do is if you're having those symptoms, you know, get to the hospital, get an aspirin, get yourself checked out, because especially in a woman, that could be a heart attack symptom.
So amazing things to know, you know, and I guess if you witness a heart attack, and you've witnessed one,
Millions.
You've witnessed lots of them. Fortunately, most of us don't. Anybody here ever have the opportunity to witness one or have to respond to one? And that's an important sense of reality for people. I mean, when people start to describe those symptoms, you have to activate your 911 chest compressions. You know, it used to be mouth-to-mouth and chest compressions. Now it is mostly just the chest compressions. And we have those defibrillators in a lot of public places now.
Right, and it's important to think of the difference between cardiac arrest. So cardiac arrest is when your heart stops, like what happened in the emergency room. Your heart goes into ventricular fibrillation or asystole, so there's no blood flow, you faint, you're on the ground, you can't get a heartbeat. And in that case, the most important predictor of survival is how soon CPR is started. And the number one means of CPR in modern times is chest compressions, approximately 100 a minute. So you go as fast, almost as fast as you can in the central chest, and the breathing doesn't matter that much. You don't need to do mouth to mouth. You don't need to worry about it. And then the second great predictor is how fast EMS, or the emergency medical services, is activated, and how fast they arrive and bring a defibrillator and shock the person back into rhythm. And those two, if those are within, say, 5 or 10 minutes on the first and 5 to 15 minutes on the second, that will tend to predict survival. But Dr. Libby is completely right. You don't need to do mouth to mouth. There's no reason to be shy about doing CPR. That's all you need. And it sounds slightly counterintuitive, but the results are actually better that way than if you give mouth to mouth. So mouth to mouth is not only unnecessary, but it is slightly potentially harmful, particularly for single person CPR. So anyway, that's cardiac arrest. So heart attack, again, is when the artery is blocked, and that leads to cardiac arrest in many patients, and is in fact the number one cause of out-of-hospital cardiac arrest and death in America, about 300,000 a year odd.
Yeah, and there are a number of them that actually are silent. So
that's correct.
That's another issue that really puts you at odds with your own personal reality, because if you ignore your risk factors, did you ignore risk factors for a while?
Only for about 65 years.
65 years. Well, it was probably a lot of fun.
Yeah. Right? Lots of burgers.
Yeah, lots of burgers. And
in fact, I had one for lunch the day I had my problem.
Oh, really? Yeah. So have you had one since? That's the big question.
No, I haven't.
I can't imagine you would. But did you know of particular risk factors? I mean, by that age, you had gone through some physical exams, you'd had blood work done, you'd had some family history explored. Was there?
You know, I did. I knew, but I knew the basic things of cholesterol and triglycerides, which to me were always off the map. But the pains and things I just knew kind of peripherally. So I'm one lucky son of a gun because, you know, I don't know how I recognized this. I was just sitting, it was in the evening, I was sitting at a computer. I had been there most of the day. And I just had this tight feeling in my chest. And, you know, sometimes I used to get shoulder pain from sitting too long. So I got up and beating my chest like I usually did, you know, 65-year-old macho. Right. And it didn't go away. And it was a little bit different. And it just kind of stayed there. And, you know, I started getting a little shortness of breath and getting a little sweaty. And as it turned out, when my friend took me in the car to the hospital, on that ride I went through what I'm told are some of the basic symptoms of a heart attack or about to have a heart attack, which we should probably tell all the policemen in town so they would know but when they're stopping somebody. But I was sweating like crazy, I was nauseous, I was dizzy, and all of these things were happening before I got to the emergency ward, and then fortunately they caught it right away. And
so Marty, you have a plan now for when you get pulled over. It sounds like.
Yeah. You know exactly what to tell them.
Right, and you look like you could be a cardiologist, truly.
That's my brother.
Anyway, so I think as we're talking about heart attacks and cardiovascular disease and coronary artery diseases we would look at for the heart attacks, we've discovered metabolic syndrome, as a gentleman over there told us when he was 350 pounds and was diabetic and realized that he was sitting on the edge of the cliff and all he needed was a little wind to push him off. And we've heard that, that certainly family history, as we understand, mom, dad, brother, sister, and my God, me, all had heart disease. Some of the other risk factors, obviously there are some that are inherent that you can't escape.
That's correct. So a large part of heart disease is genetic, and a large part is also your lifestyle. And we like to think that hamburgers are one of our best sources of business. So it's a reality. I think smoking even beats that, by the way. But the biggest risk is tobacco abuse. So the number one way to get to a heart attack is to smoke cigarettes. A second is to develop diabetes. That's a very strong predictor of heart disease. Approximately 75% of people with diabetes will die of vascular disease. A third is high blood pressure, hypertension. Very easy to treat in modern times. The incidence of stroke in America has probably declined about 90% since the 60s. That's because everybody takes medications for hypertension. The prediction of getting hypertension is actually quite high in America. Most people get it. It's just a question of when. So it's good to check with your doctors and check your blood pressure periodically because we'll all eventually get it more or less. Another one is high cholesterol. And again, we've made remarkable inroads on therapy of cholesterol. Most people are on statin therapies. There are guidelines that we go through to decide who needs treatment. But the number one treatment is people who already have heart disease. And then other risk factors get more complicated. Certainly early family history of heart disease is a major risk factor. Metabolic syndrome, which is a disease entity defined by a number of different variables, including enlarged centripetal obesity with a big abdominal girth, usually 38 or so inches, impaired glucose tolerance or insulin resistance, but maybe not overt diabetes mellitus, a low good cholesterol, and a high triglycerides are among them. I think there are a few more. That also confers a very high risk. And then there's a bunch of other risk factors now, and there's a lot of genetic markers out there for risk. So, for example, when people get cholesterol tested, we recommend a test called lipoprotein little a. And LP little a is a strong risk, actually only in white patients, though, only in Caucasians. And for example, Bob had a very high LP little a. If a normal LP little a is less than 15, then an LP little a above 50 would be conferring the highest risk. And I believe some other family members of the patient here also have high LP little a's. There are other genetic markers. There's a KAF protein, which is obscurely used. And then there's another genetic marker on chromosome 9 that they can be tested. A lot of these can be tested now, if you're interested. The last thing that everybody should get tested in modern times is a high sensitivity C-reactive protein. So HSCRP was a blood test developed by Dr. Paul Reicher at Harvard, and it gives a level of inflammation in the body which at a certain point is actually arterial inflammation. And that inflammation tends to make the plaque or the cholesterol lay down in the artery and possibly help precipitate rupture of that artery or rupture of the plaque, in the artery. So those are the people who are at risk should get their cholesterol tested with lipid panel and a high sensitivity C-reactive protein. If you're really worried, you can get these genetic tests. You can check for your blood pressure, you can check your blood sugar or a hemoglobin A1C, which is another test for diabetes. If you really want to get subtle, you can check a fasting insulin level, which is a test for prediabetes. And then they should also quit smoking. Obviously exercise, we talked about that. The current recommendations, I believe, are 30 minutes moderate exercise at least 3 times weekly, or 20 minutes vigorous exercise 3 times weekly. But we'd like people to go 7 days a week. And just so you know, walking around the hospital and all that, if you're so inclined, counts as exercise. Hard to believe. And you would also want to obviously eat a cardiac prudent diet. The most typical American prudent diet is called calorie restriction. So if you can restrict calories, that's usually a good thing. And after that, we restrict highly trans fats. So trans fats are the fats in some kinds of butter, some kinds of margarines, Crisco, occasionally some processed foods have that in it. And then saturated fats, which are the ones that sort of are solid at room temperature. So they make that solid fatty streak inside your artery, if you think of it that way. That's in, basically butter, lard, schmaltz, meats, chicken, skin, things like that. And we encourage, contrary-wise, the consumption of fruits and vegetables and whole grains, and perhaps, although it's not been proven, foods with relatively low glycemic index, how fast the food sugar gets absorbed. And we absolutely proscribe or deny people things like sugar beverages, particularly Coca-Cola, things like that should not, cola beverages, sorry to mention a product. Also, one could argue that you need to be careful with juices and some sort of kind of seemingly benign drinks that have a lot of sugar content, or even thought to be even worse, high fructose corn syrup. So that's how all those risks go. I don't know if I went through it enough. I think I got everything there.
An important component, of course, being the diet issues. And then we know that diabetes, a remarkable thing. I mean, 17, 18 million people know they have it. Probably another 25 million are pre-diabetic, but somewhere close to another 25 million really have no idea that they have diabetes, and they're walking around that way. And they are developing all of the risk factors unbeknownst to them. So that's important. And obesity being such a predominant body form in our country now, in particular in the pediatric population, it's something that I deal with on a daily basis. We have remarkably somewhere close to a third of kids who are significantly overweight and bordering on obese. And I was reading an article today about the fact that many of these kids who are obese will have high levels of that C-reactive protein. So they're already starting to develop the foundation for significant heart disease. And in fact, when they look at their arteries in adolescence, they see plaque building up already.
Right, that was the studies of people who passed during the Vietnam War actually showed that atherosclerosis had already started to build up in 18 to 22-year-olds in America. And that was then, it's much, much worse now. And so, right, so childhood obesity, there is, creates a number of issues. And one of them is that the thinner you are, the longer you'll live, especially when you're thin and young. And as you get older, that advantage changes slightly. So if you're very, very old, then you're actually a bit better being, say, 10% above ideal body weight. But we recommend, and I'm sure Dr. Libby does, following body mass index, which is a parameter where they take your weight in kilograms and divide it by your height in meters, but then they square it. So they divide twice by your height in meters. And that will give a number. So less than about 18, so about 18.5 to 25 is considered normal. That's a normal body weight. Note that they don't care if you're less than 18.5, by the way. That seems to be left open. 25 to 30 is overweight. 30 to 40 is obese. And greater than 40 is morbidly obese. Morbid means, very sickly obese. There are body mass index calculators online. It is a good idea for people to think about their body mass index. It's important, especially in children as well. And I believe, unfortunately, our current statistic is approximately 66% of Americans are overweight or obese, and kids, it's about a third now. And I think we need to relook at how we get people out and being active as children. Children need to get out of the house. They can't watch TV. Parents need to be restrictive about food. And we need to set an example for our kids. We don't buy soft drinks at home. We don't buy, I love potato chips, for example, but I'm always struggling with my weight. So we try to avoid buying potato chips at home as well. I'm not saying we like saints, but we're not, certainly people don't have meat every night. And if your kid doesn't want to eat anything, that's great. That's peachy. If my daughters say to me, hey Dad, I'm not hungry, hey, fine with me. So I can also chime in on, and especially in tiny children. I remember we had a friend who had a 2-year-old child, and they would put all this food next to this child right around the little, on the high chair. And the kid would be grabbing at food, and the kid was a big powder ball. And unfortunately, childhood obesity of less than 2 of age tends to predict adult obesity as well. So really, I think it's important to have skinny children. That's the best way I'd put it. And anything you can do to keep your kid skinny is it's almost a national crisis if you believe the Department of Defense. We need to get our kids skinny. You need to get them out playing basketball or bicycling or doing things. Again, I'm not saying I'm a saint or our family, but it is very, very important. And I could chime in on school lunches as well. I think a good appropriate school lunch for children is 3 things. It's a glass of water, an apple, and a small bowl of oatmeal. And I think if everybody, if that was the school lunch in all of America, it would be great. And if kids didn't eat it, again, that's great. If your kid doesn't want to eat food, hey, this is wonderful. Don't lose sleep. In fact, it's the best thing that can happen to that child, to choose, for whatever reason, not to eat. And people, my family's Italian. I was overseas in Italy. My aunt, if I didn't eat, she thought I was dying. But after a while, how much can you eat? But anyway, it's the wrong way to do it. I always say, there are people starving in China, but obesity is our national problem. So forget, if you don't want to eat your food, don't eat it. I don't care.
Yeah, and we do have, finally, the school system is looking at vending machines and the quality of the food that's being served. And I think that there is a big initiative, and they really recognize that. The hardest part is to get that physical activity, which You know, we say for adults is important, for kids is super important. But sort of changing direction a little bit, you had a pacemaker.
Right.
So you must have had some kind of problem that, well, was related to
Well,
the rhythm of your heart.
Yes, yes.
Tell us a little bit about what happened there.
Well, for several months I had had, as I said, pounding of my heart,
Right.
and also high blood pressure, and weakness in my limbs, and shortness of breath. And when I got to see Dr. DiLorenzo, when he saw my EKG, he said something that I didn't understand, but he explained it to me. He said, "Your heart is completely blocked." And it's not the same as what we've talked about here so far about blockage. And so I found that very interesting to find out from Dr. DiLorenzo what was actually wrong with me. And it has to do, he can explain it, it has to do with electrical impulse.
So you had been fatigued for weeks.
Yes,
You had
absolutely.
noticed that.
Yes, but it was only after she'd had the pacemaker implanted and I saw how much her energy level had risen that we both realized how weak and how vulnerable she'd been.
Yeah.
Yeah, I felt like a new person.
Yeah.
I really did.
So you had a heart block. You had symptoms that were subtle, more just like fatigue and things that really were rather.
Well, the heart pounding really
Bigger.
scared me.
That so.
Yeah, it was really affecting me.
Did
and
you have any other kind of condition that may have contributed to it that you're aware of?
Not that I know of. No.
Okay.
No.
So just changing direction a little bit, rhythm disturbances, because that's a big part of cardiology beyond the heart attacks and the atherosclerosis. We had something here that was called a heart block.
That's right. So our hearts are electrical organs, and our heartbeat starts sort of high up in the right atrium. We have our own pacemaker, and near a vein called the superior vena cava, we have a sinus node. It generates a little electrical impulse automatically, and that impulse then goes down through the upper chambers of the heart, the atria, the filling chambers, and it goes to the atrioventricular node, and then it gets slowed down slightly and then distributes out to the ventricles or the pumping chamber. And by doing that, you maintain heart synchrony. The filling chambers get the blood, they pass it on, a little bit of time delays, the ventricles now have time to fill, and boom, they push out the blood. So her problem, Susan's problem, was that the beat stopped halfway. So as her heartbeat came down, it simply stopped. There was no conduction at all. So it was not a blocked artery, it was a blocked conduction, and it's usually in a part of the heart right below the AV node that has a wonderful name of the His-Purkinje system. Very easy to remember for medical students and residents and all those folks. And it's usually due to a almost a slight microscopic scarring of the heart, almost a fibrosis of that part of the heart. And why it occurs in some people and not others is tough to say. And it can occur older, but occasionally we see it younger. And the treatment in modern times is quite simple. We simply put in a pacemaker. And the pacemakers are put in right up here in the shoulder. We put wires down to the upper chamber, wire down to the lower chamber, and then we connect the wires in a pacemaker box, put that underneath the skin, and the pacemaker box, in Susan's case, actually finds, so her heartbeat starts just like it normally does. The pacemaker finds it or senses it and then conveys it down to the lower chambers. So her pacemaker is physiologic in the sense if her heart goes faster, her heart goes faster. If her heart goes way too slow, the pacemaker will kick in. But most of the time, her pacemaker is simply tracking her heartbeat. And in any case, that condition is called complete heart block. There are other conditions that require pacemakers. The other big one is second-degree heart block type 2, and high-degree AV block, but there's a number of them. And then we do see a number of other rhythm disorders. The most prominent is atrial fibrillation. So atrial fibrillation is commonly associated with blood clots forming in the chamber of the hearts, not in the arteries, and then people will throw those clots and get a stroke. So we have to thin the blood. Occasionally people get a lot of rapid racing heart or palpitations, and we need to get the heart back in rhythm or in some way quiesce those symptoms. There's another rhythm problem we see mostly in young girls, by the way. That's SVT, supraventricular tachycardia, so the heart goes fast with the reentry circuit, and that causes just sustained palpitations. And again, that's actually now treated by electrophysiology doctors, where they can basically burn a part of the AV node or a concealed bypass tract and then correct that. I should mention also atrial fibrillation, which is very common. About 8% of people over 80, I think, or if not more, have atrial fibrillation, can also be treated with electrophysiologic techniques as well. So there's multiple therapies: blood thinning, rhythm drugs, and EP techniques.
And the usual cast of characters are creating the risk factors for those folks.
Well, atrial fib, right? So there are genetic causes. No. So her complete heart block has nothing to do with conventional risk factors, and is it's not. There's why do you form a little? One day you find a little scar over here. Why did that form there? Well, I'm not sure. Why did it form your heart? Well, neither are we. So there may be some familial predilection to need for pacemaker with complete heart block, but it's not that great as far as I understand. Atrial fibrillation definitely has a familial predilection or a tendency to run in families. It is associated mostly with high blood pressure and congestive heart failure, so weak heart. But many people have, and thyroid disease and a few other things, but most people we see who are young, it tends to occur for no particular reason. I have a couple of people, very athletic doctor I know who has it, a friend of mine who has been in the best of health all his life has it, for no reason at all, but not conventional risk factors.
And we have an athletic fellow right here. Now, you were telling us earlier about you were playing rugby, and you knew you had something abnormal with your heart. How did you ever find out that was abnormal in the first place?
I actually found out before I started playing rugby. I just went in for a routine physical. I was concerned about my cholesterol. My cholesterol was fine, but they heard a murmur, had a lot of tests done, found out I had a bicuspid aortic valve, and that really, I had a pity party for about 5 years. But I started seeing Dr. DiLorenzo on a regular basis, once a year, having an echocardiogram, and he told me, hey, you may have to have something done one day, maybe not. We'll monitor it every year. You have no limitations. So 5 years after finding out about my bicuspid aortic valve, I began playing rugby. So I felt really good about that I was kind of beating the system here. I was proving that I was okay. But after a few years of that, in one of my annual follow-ups with Dr. DiLorenzo, he found out that it was causing the stenosis was starting to cause my left ventricle to enlarge, and there were electrical changes, and he told me I couldn't exert myself because there was a chance of sudden cardiac death. And of course I argued about that. I said, what are the odds, Doc? And he said, well, the odds are relatively small, but it's a pretty permanent condition. So at that point we talked about having it fixed, and we had it fixed. Had the Ross procedure, which is a kind of a specialized, I guess, a fairly rare way to fix it.
So that was a surgical procedure?
Yes.
Yes. Okay, so we've not had enough time to really talk yet about what people have to do once they go through this experience. You work in the rehab department.
That's correct. So what we do when someone has been diagnosed with heart disease is help them pull all the pieces together. Frequently what happens is that they're assigned a lot of tasks. They're assigned to lose weight, to start exercise, to stop smoking, to eat healthy. The information is information overload for many of them. On top of it, there's a lot of anxiety, a lot of insecurity, a loss of confidence on how active they can be and how they can achieve all of these goals. So what we offer is called cardiac rehabilitation. What we do is a clinically supervised exercise program, so we're looking at heart rate, blood pressure, heart rhythm as we progress them in an exercise program, communicating with their physician during the course of the program if we see anything that's a little bit out of normal, and getting them up to a point where they're doing a good 45 minutes of cardio or aerobic exercise. They're doing stretching and flexibility exercises, and they're doing strength training. And then we have, in addition to that, a whole education program, helping them to learn to live with the heart disease and change the habits that may have led to the development of it. So we look at diet modification, we look at stress management, we look at managing their diabetes appropriately, all the different risk factors that could have led to the development of heart disease. We're teaching them how to manage those, and so that I always tell people medical science can keep you alive for a long time, but how you control it and what your quality of life will be is really up to us, up to each individual. You need to make the adjustments so that you live a long life, but you also live a healthy life and a good, high quality life. So that's what our goal is, to help them achieve that. So your goal is to get 3 to 5 days of exercise in a week. Do you think you're doing that, or are you still
Well, I get the 2 that I come in here.
Okay.
And then sometimes the 3rd.
Third day? Okay.
You do a great job, and thank you for what you do there.
Thank you.
And Gail, you come from the American Heart Association. We got just a brief second to talk a little bit about what they do and what kind of information they put out there.
I was chosen as a national spokeswoman for Go Red for Women, and what we really want to portray is that 80% of heart disease is preventable. 1 out of 3 women will have some sort of heart disease. 1 woman dies a minute of heart disease. In fact, more women die a year than men of heart disease. 500,000 women will die this year of heart disease. And if we do the right diet, which the Heart Association recommends 5 to 7 fruits and vegetables, and the same sort of thing that Dr. DiLorenzo has said, and at least 5 days of 30 minutes of exercise. And the one thing that I always say is if it's raining or snowing outside, you can walk the perimeter of your house for at least 30 minutes. If there's a will, there's a way.
I want to thank you all for being here. You were great. Your stories are amazing. People could really connect. And of course, Dr. DiLorenzo, thank you so much for being here.
I just want to say a word of tribute to Bashara Ackle, who was the unbelievably brilliant Inova Heart and Vascular Institute surgeon who did the Ross procedure for Bill. And he would be, Dr. Ackle passed away a couple of years ago, and he would be so proud to know that Bill is still doing well, and that his surgery has held up perfectly over the last 11 years. Remarkably, it's almost as if he's never had surgery at all. It's such a perfect job.
And of course, Dr. DiLorenzo, thank you so much for being here.
Thank you for inviting me.
Great information. And of course, until the next time, I'm Dr. Russell Libby, looking out for your health.